So when you look at the emergence profile, you look at the trajectory of the implant, and then we can place the implant, and you can see that we've positioned the abutment so that the flat of the hex is towards the facial. You can see the amount of soft tissue, and this is the 3-in-1 abutment from BioHorizons that we may or may not utilize to do the final restoration. You can use it to do the final restoration, or you may elect to use a different type of component. So there are no surprises when we go to the prosthetic phase. We have a soft tissue model, everything, the trajectory is exactly as we had planned it. The sulcus formation is going to be good, the emergence profile is going to be good, and here we use, for this particular patient, for this particular receptor site, a 4.6 millimeter implant to replace a maxillary central incisor. So the 3D planning concepts showing the positioning of the interproximal height of bone, the abutment, and the emergence profile allows us to be able to help develop the soft tissue profile, the depth of placement of the implant so that we can have enough running room to emerge the restoration from the site and be able to then have a successful result. And when we look at the postoperative radiograph, we can see, in fact, that we have the interproximal height of bone exactly as it appeared on the virtual plan. And so we have successful result. So these 3D planning concepts allow us to be able to look at the adjacent teeth, the roots of the adjacent teeth, not just the teeth themselves, the coronal aspect, but the roots using selective transparency. We can understand interproximal contacts. We can look at the interproximal height of bone in ways that we've never been able to do before, and then we can look at and evaluate the emergence profile before we ever touch the scalpel to the patient. And so there are a whole bunch of new tools, new software. BioHorizons specifically utilizes their VIP software, which is based on implant logic systems by my good friend Dr. Michael Klein, allowing for interactive 2D and 3D treatment planning software and the creation of surgical guides, surgical templates. So there is a various number of software applications that are out there, but what's really important is that we understand the 4 major views. The panoramic view that you see here in the lower right, the cross-sectional view on the lower left, the axial view in the upper left, and then of course right here on the upper right is the 3-dimensional reconstructed view that everyone can understand. It's putting all of those pieces of the puzzle together that allow us to be able to develop a sound, predictable, and accurate plan that helps us to communicate with our patients, communicate with our referring doctors, communicate with our laboratory technicians. Everybody becomes part of the team to be able to complete this type of result with consistency and predictability. And so when we utilize many of these software applications that exist today, I just encourage you to learn about them so that you can incorporate that into your daily practice, whether it's a single tooth or full mouth reconstruction. Sometimes a single tooth will give you much more heartache than anything else. So today we have different choices of our abutments. We can use stock abutments that come right off the shelf, and as many of the companies have, there are different diameters, different color coding so that we know which implant goes with which abutment goes with which implant. Here you see the yellow, the green, and the blue from the BioHorizon family. And this is called the 3-in-1 abutment because basically it serves 3 different purposes. But I'm actually going to show you how it serves a 4th purpose as well if time allows. Sometimes we may elect to use a different abutment. In this particular case, one of the choices would be the simple solutions abutment. This is an abutment that, from my philosophy, goes into the patient's mouth and should never be removed. And so in order to accomplish that, we would need to do an abutment level impression, and we need specific restorative components to allow us to be able to do that successfully. And so here you see there are different heights of the abutment, different tissue cup heights, and it can be utilized on any of the implants that have an internal type connection. So that means that we may actually have a different choice in terms of our impressioning. And in this particular case, we're looking at a fixture level impression, which we would utilize with the 3-in-1 abutment, or an abutment level impression that we may elect to use with a different solution, which in this case would be the simple solutions abutment. And so this type of innovation is something that is familiar with many different implant systems. Today I'm just focusing right now on some of the applications in the diagnosis and the treatment planning so that we can show you how we can utilize some of these components. The 3-in-1 abutment is called 3-in-1 because it delivers the implant to the patient, serves as the implant mount. It is an impression coping, as I just demonstrated, and it can be used as the final restorative abutment. So it's tremendous prosthetic flexibility, and if you orient the flat of the hex towards the facial, you'll be able to utilize and expand your use of the stock abutment family offered by Bar Horizons or any of the other companies that you may use. And we talked briefly about the laser lock micro channels. When we start to look at that and some of the other different dimensions and thread designs of the implant family, here you see an internal implant on the right, and you see on the left a single stage implant. So the single stage implant is going to emerge above the bone in this area here, but you'll also notice the laser microtexturing is going to be, or microchannels are going to be applied on both of the implants. I happen to prefer this particular design. This is the tapered internal implant. This is my go-to implant right now, and I believe that the internal hex connection allows tremendous prosthetic flexibility along with the family of abutments and custom abutments that can be utilized. When we look at the laser lock microchannels, again, we're looking at trying to maintain the collagen fibers and the bone levels to be able to create, in fact, new connective tissue attachments. And it doesn't matter which thread design that you use, the thread designs also have an application within the technology to be able to support the ultimate restoration. And so our concern here is how do we maximize the design of the implant to the receptor sites that we're going to use. And again, some brilliant research that has been published by Myron Nevins and his group, Human Histological Evidence of a Connective Tissue Attachment to a Dental Implant. Great reading. Try to get a copy of that article if you're interested. So if we use a conventional bone level implant, and we're going to place an abutment on that implant, we know that the margin of the abutment is going to be at the level above the tissue. And so for a cement retained restoration, we don't want the margin to be too below the tissue because then we have cement entrapment. So we want to prepare these abutments. And in fact, we actually have a hands-on course that will be offered next year, and you can check with Dental XP, you can check with Bar Horizons for some of these hands-on courses that we're going to be offered, and we call that the 3 A's in achieving prosthetic success, and I'll mention that at the end. And so having that marginal configuration here that exists on the implant, it needs to be prepared, it needs to be treated so that we have enough room for the metal and the porcelain. Now we're dealing with a single stage implant, or one where the implant margin is above the tissue. Then we have a little bit different consideration, because then we have to manage the soft tissue and we have to manage the site. And so this particular implant design, I believe, is better utilized in the posterior mandible or posterior maxilla, and certainly not to be used in the anterior maxilla or anterior mandible, unless you're doing a fixed detachable type case. In that case, for a fully edentulous situation, it's an excellent implant to use. And so regardless of which implant, you're going to have an internal hex type connection, of course, with all systems, different diameters and different sizes, as we've discussed. But also the different stock abutment choices become very important to be able to allow us the prosthetic flexibilities that we need to be able to achieve the success. And so having this simple solutions abutment or the 3-in-1 abutment gives us tremendous flexibility. So let's talk about another case here, and this is a final x-ray actually, and it's kind of interesting when you start to look at the final x-ray first, and then I go back and explain how the case was done. So let's talk about restoratively driven implant dentistry and the application of some of the technology that we've just discussed. So here you see a patient that comes in, and we're going to discuss the posterior right side, and we can see where the inferior alveolar nerve traverses through the mandible, and we can see, very, very clearly that this patient is having a problem, but it might be better if I blew up that area so that you can see it a little bit better. So here you can see the defect that exists here, maybe some fracture in this tooth, decay certainly under this 4-unit bridge in the posterior mandible. And so when we start to evaluate these cases, I like to kind of visualize in my mind, and in this case we actually came up with some drawings to be able to kind of give me a goal. And that goal is to place either 3 or 4 implants to replace the 4 missing teeth in this area. And so using artistic license, if you take a look very closely at this, you'll see that this artist created this image showing the implant at a supracrestal placement above the bone. Now, for many different systems, that may not be something that is desirable. But you'll notice also there's a demarcation between the 2 zones, and there are 2 zones of the laser microchannels. We'll discuss that in a little bit more detail as we go along here, because how do we plan to place an implant into these areas based upon the design of the implant? Well, we're also going to use a protocol because of the patient's desires to do an immediate extraction, immediate placement, and have the patient walk out with immediate restoration. So here's the preoperative radiograph, and based upon the defect in the molar, we elected to only place 3 implants, and we're going to do a bone grafting procedure where the large molar defect was on the posterior right side. And so you can see that the bone graft material was placed here in this area, and this is the immediate postoperative radiograph. And so looking at the 3 implants, we created a cantilever bridge. The patient walked out with a restoration. But how did I have the confidence to know that I could do that? Well, of course, it's going to start in the 3-dimensional planning. So if we take a look at the 3-dimensional planning, we're going to see in this particular case that we have a cross-sectional image, and that cross-sectional image allows us to clearly indicate where the path of the inferior alveolar nerve is. We can clearly indicate where the thickness of the facial and the lingual cortical plates are, and we can evaluate this patient's individual anatomy based upon this cross-sectional image. And sometimes it's kind of an eye-opening experience for when we're looking at individual patients. We can then place a virtual abutment, and we can try to avoid the concavity that exists in this particular area, as you can see here, and also give us a zone of safety above the inferior alveolar nerve. So when we have that capability, we can even place an implant in areas where we might normally not place it, above the mental nerve. So here we can see where the mental nerve exits through the mandible, and that really is an amazing evaluation. We can see the thickness of the cortical bone on the lingual aspect, and we can see, of course, that lingual concavity that we certainly would not want to perforate. So looking at these cross-sectional images, we can see where the position of the tooth might be. We can evaluate position to place an implant. We can place a virtual implant, but then we need to extend some sort of a prosthetic extension of the abutment through the occlusal space, because we need to be able to connect, again, the implant itself with the abutments and the tooth. And in order to be able to do that, we need restorative tools in our virtual world, because the goal is to utilize the 3-in-1 abutment to be able to put this patient into an immediate restoration. And that's what we try to be able to achieve. In order to be able to maximize the laser lock microchannels, we also have to kind of consider the science behind it and what the manufacturer actually recommends in the placement of these types of implants and this coronal application. And so BioHorizons, as the manufacturer, recommends actually 3 different types of placements for this implant. One is as a bone level implant. We'll place it at the level of the bone, and then we call crestal placement. And so if you notice, the implant is placed directly at the crest of the bone. But I want to warn you that when you're starting to look at these examples, you're not going to see this type of bone on the facial and this type of bone on the lingual very often. That thickness of cortical plate just doesn't exist, at least not on my patients. And so when we have the ability to be able to assess the receptor site in 3D, we have the ability to be able to analyze that and get our accurate, predictable results. Now, supracrestal placement I mentioned earlier, and that's where the implant is actually placed above the level of the bone crest. Now, we won't do this with many implant systems, so how can we be confident that we place the bone in a supracrestal position, that we're going to maintain the bone, and we're going to maintain the soft tissue? Well, that's actually the application of this laser lock microchannels. So if you have the confidence that the science is true, then you should have the confidence that this is going to be a consistent result for you. I believe, however, that in most cases, as I mentioned very early in this broadcast, and that is that the ideal receptor sites really don't exist very often. So most implants are not placed into ideal receptor sites. And in fact, they look more like this, where we have a higher lingual cortical plate and perhaps a lower facial cortical plate of bone. So in order to do that and preserve the bone at its height on the lingual, we're going to place the implant in what we call a transitional placement. That means that part of the implant is actually going to be exposed on the facial, where there's deficiency of bone, or maybe the mesial, or maybe the distal. And so having that capability within the science of the technology of the design of the implant gives us tremendous surgical flexibility in the placement of the implant within a receptor site. Now, can we prove that? Of course, if we have the three-dimensional picture, as we can see here, we can look at a three-dimensional picture and the placement of this implant within that transitional placement concept. And so we're going to actually maximize this transitional placement based upon the patient's actual anatomy. And so when we do this, we can look at the realistic implant, we can look at the transitional placement, keeping the cortical bone on the lingual, not flattening the ridge, so that we can also position this laser lock application exactly where we want it to be. Having that capability gives us, again, tremendous surgical flexibility, as long as the implant is placed within the restorative envelope. In order to be able to see the restorative envelope, we need to be able to do a three-dimensional reconstruction. The three-dimensional reconstruction that you see here is one of the existing bridge. So what you're looking at in the purple color or magenta color is the existing bridge. And then we can magically, through the use of our computer software, make that disappear through a process called segmentation, and we can then place our implants within the bone. Unfortunately, just doing this step is not enough, because we really need to be able to extend our restorative elements through the occlusal aspect of the teeth so that we can see where the embrasures may be, so that we can see where the emergence of the implants are within the occlusal table of the individual teeth. And so utilizing our selective transparency, we're going to be able to see how we can avoid the adjacent tooth roots, how we can avoid the inferior alveolar nerve, and allow us to be able to have a predictable result doing what I call 3D restoratively driven planning. This is a whole new paradigm, because now we can see that we've rebuilt a new occlusion in this area. We can see the contact position, and in fact, here's the fourth implant where the molar extraction was, and that defect was way too large to place an implant immediately. So we elected to place that after bone grafting approximately 5 months later. So the visualization was to have 4 implants initially, but we only placed 3 based upon the defect in the molar area. And so as we start to look at these various examples, we can start to look at the emergence profile. We can evaluate this from the occlusal view. And again, here is that large defect that you can see here, and it allows us to be able to, choose which implants we're going to place and which ones, are in jeopardy, and therefore bone grafting would be a much more accurate and predictable choice before the implant is placed. Having the capability of slicing through the three-dimensional reconstruction allows us to be able to see the lingual concavity, the cortical plate, here's the mental nerve, and then we can see the emergence as it goes through the clinical crowns utilizing virtual occlusion or virtual teeth. And so having this capability allows us to then port out this information, get a surgical guide, and utilizing the surgical guide, creating, in this case, through stereolithography, we're going to do something that I pioneered many years ago, which is the application of model-based surgery. Model-based surgery allows us to be able to go in, to be able to actually utilize a stereolithographic model, to be able to place implant replicas within that model of the true bone position for the patient. And having that capability allows us to understand, again, implant to implant distances and plan for the correct position so that the implants will emerge within the body of the tooth. And so we have a diagnostic wax-up on this stereolithographic model. We can evaluate that stereolithographic model. We can see the position within the framework of this transparent vacuum form matrix over the diagnostic wax up, where we can see the individual 3-in-1 abutments that we're going to use as the temporary abutments for the restoration. You can see that there's 4 of them. Initially, we only used 3. So now we have the implants that are parallel. We're going to orient the flat of the hex towards the facial, and we're going to be able to go to the surgical intervention. Now, we'll contrast this with the simple solutions abutments. Let's see if we can get that back here. And the simple solutions abutments have a family of different restorative components that allow us to be able to capture the margin, leaving the abutment in place. But for this case, we're going to use the 3-in-1 abutments that come with that have in the past come with all of the implants from BioHorizon. Today, you can actually get them separately. We're then going to create from our laboratory colleagues a temporary restoration, and then we have the confidence to go in, remove the existing bridge, look at the concavity on the facial surface, look at the amount of bone loss that we have in this area here, and the minimal amount of keratinized tissue. So if you pay attention to the width of the remaining tooth, the molar, the width of the remaining tooth in the anterior section, and you can see the amount of defect that has occurred from the lack of having the roots in the bone, this is something that we're going to also address and try to restore. And so it can be pretty scary if you promise the patient an immediate restoration and you open up the flap and this is what you see. But if we have a stereolithographic template that is a CT-derived template, we're able to go in, place the implants where we want, flat of the hex towards the facial, all planned with the flat, 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 all planned to be placed within the transitional zone, and we'll show you that in a little while again. Patient walks out with a fixed restoration, no more ridge lap, there's no more concavity in the vestibule. Here you see the occlusal shot here from the lingual aspect. So we have good morphology, and we're going to allow this to remain in place for approximately 8 weeks before we touch it. Of course, we're going to remove the sutures prior to that. And so, patient, again, to remind you, walked in like this with a defect, and we're going to extract, place 3 out of 4 implants, and bone graft in the area where the molar is. About 5 months later, we're going to come back, we'll put a new implant into where the molar is, and then we'll finish the case. So again, new paradigms, 3-dimensional planning, the use of model-based surgery with stereolithography, and understanding the transitional placement to maximize the design of the implant that we're going to use. So 3D realistic abutment planning allows us to be able to achieve results with great predictability, great consistency. And so, again, just to reiterate, where the flat of the hex becomes important is when we're starting to deal with the, let's see if we can go here. We're starting to deal with other abutments that may have pre-machine margins, lower on the facial, higher on the lingual, and therefore that flat of the hex orientation becomes important. Otherwise, we're not going to be able to utilize some of these newer abutments in these areas. And so it becomes critical, again, one of the first pearls that I mentioned, is orient the flat of the hex towards the facial. About 5 months later, we put the final implant, we let it heal. In this case, we did use a pre-contoured abutment on the posterior abutment and the 3-in-1 abutments that were prepared in the anterior segment, and we're able to then use a positioning jig to place the abutments in the mouth. I highly advise this. Regardless of what system that you're using, your lab should make you a positioning jig that will help you orient the rotational position. We're going to do a metal coping try-in this particular case, and when you start to look at the occlusion, this patient was a bruxer as well, which will explain why we used 4 implants rather than 3. But if you take a look on the laboratory bench and you look at the occlusal view, as you can see here, there would be no indication that this was an implant-supported restoration. When we look at the soft tissue housing that we've been able to develop, there's no more ridge lap. We have good soft tissue depth and now we will, as the area starts to mature and heal, the soft tissue response is what we're looking to achieve. Here we see the bisque bake, and we're going to try this in. You can notice a little bit of a blanching of the tissue on the right side of the screen here. And so as we start to do that, we want to evaluate the embrasures. There is no ridge lap in this particular area. And so this is the final result, what I started off with showing you. And so now if you look at it a little bit more closely, it may make more sense. Here is the bone grafted case, the bone grafted implant. This is the transitional placement here. You can see where the bone level is, exactly as we had planned it. And here you can see we have one interproximal peak of bone, and then the remodeling that occurs directly in this area down to the zone between the 8 and the 12 micron grooves of the microchannels for the laser lock surface technology. Now, this case is kind of interesting, but I think it would be more interesting if we start to look at not just the periapical radiograph, but we start to investigate this a little bit further in terms of, did we really achieve the philosophy that I have and the philosophy of the technology of this implant? Well, let's take a look at the final restoration. We were able to make a restoration that was aesthetic and functional for this patient. He was very happy. We were pleased with the outcome here as well. And so, wouldn't it be nice to have a post-operative scan? So now we're looking at a year and a half later, and what you're looking at in the upper left-hand screen is a post-operative CT scan, cone beam CT, of the 4 implants. The dark line that you see is not bone loss. This area here in between, that's called beam hardening. It's an artifact of CT and cone beam CT, and so that's nothing to be concerned about. But let's take a look at our planning. And if we look at this year and a half later, we can see that we've been able to place the anterior implant exactly as we had planned. Let's move to the second implant, as you see here. And the second implant is placed within exactly the plan that we had originated. In this case, this was the one that we placed the implant near the mental foramen. So if we take a look at that positioning, we have developed a zone of safety that gives us the confidence based upon the plan that we started with. So again, here's the plan, there's that mental foramen, and this is the actuality based upon the use of the surgical guide and the surgical template, and utilizing a tapered design implant like the tapered internal, we're able to avoid the lingual concavity in this area. So we're applying the science that we've learned using new paradigms and new tools of 3D planning. Now here's the third implant. Same result. Third implant, in this case, we're avoiding again the lingual concavity, and we have nice amounts of bone around the implant. The implant is pretty much smack dab in the middle of the tooth that we try to replace. Restoratively driven implant dentistry. And so here's, I think, probably the most impressive to me. This is the fourth implant, the one that we placed in grafted bone a year and a half later. And so when we take a look at this implant and this placement and this accuracy based upon placing a tapered implant, look at this zone right here. We've missed perforating, fortunately, because that's exactly as we had planned it. But look at the amount of bone that we've regenerated around this implant. When we start to think about the initial plan, and we go back to it, we can see the amount of bone that was missing. In this case, we grafted first. So sometimes it makes much more sense to graft than to go in and just haphazardly place our implants, because we're trying to get them in and not place them into a good receptor site. Let's manage the receptor site, come back later. Patients will understand. Not everyone's in a hurry to get their work completed. And so based upon this type of technology, we have to understand that it's not the scan that is important here in the diagnosis and the treatment planning process. It's not the fact that we're using this technology. It's not that we're using laser lock microchannels. It's the understanding that we can achieve predictability, we can achieve accuracy, and it's not the scan, it's the plan. And that's really the very important part of what we're trying to talk about today. And so utilizing some of the technologies that we have, we want to be able to make sure that we have the ability to be able to understand where we have been to understand where we're going. And three-dimensional imaging technology is here today, and it's going to be staying. I'm very fortunate to be president of the Computer-Aided Implantology Academy, and I'm very excited that this weekend we're having our very first international meeting in New York City. It's our 5th annual meeting, and what's interesting is, and for those of you who are from countries not from the U.S., because I know on the Dental XP site we have countries from literally all over the world. There is so much more guided surgery that is being done outside the U.S. than inside the U.S. That this is why organizations like the CAI Academy, the Computer-Aided Implantology Academy, become so very important for us. And so we're having our meeting this weekend at NYU, and I'm very excited about that and seeing all of my colleagues. We have about 20 different countries that are represented within this meeting itself. Again, if you want to catch up on a couple of books and a couple of other areas that you might want to read up upon, textbooks, I can recommend several books, all that I have chapters in, and some that you would recognize many of the other names. One of particular interest is the Art of Computer-Guided Implantology, as you can see here, or the Yakstad's book, Osseointegration and Dental Implants. And then more recently, 2 books that came out recently this year, the Dental Implants, The Art and Science by Chuck Babish, and which is a tremendous second edition. And if you'll notice the pictures here on the right side of the screen, you can see all of the guided surgery applications that have been added. And then one book that I think everyone should have as well is a great book that just came out on dental implant complications. Fantastic book by Stu Fromm, again out of NYU. So if you'd like to learn more about some other courses, please contact the Dental XP. We're going to be doing some hands-on courses, the 3 A's in achieving prosthetic success: abutment selection, abutment preparation, abutment connection. I thank BioHorizons and Dental XP for allowing me to be able to present to you today, and hopefully we can have a question and answer period that will follow. So thank you very, very much for your kind attention.